Now that we have done an MRI, we will have to be very clear about the basics about how to read an MRI and what is it that a surgeon would like to know from the MRI before, during and after the surgery. So let us start talking about this aspect of MRI study and to know what is it that we need to look at. To put it very simply, in case of MRI, we are also trying to understand the change in the pathoanatomy. This is the vertebral body, this is the foramen, the inferior articular process number 4, number 8 is the pedicle, number 5 is transverse process, number 3 is the spinous process, number 2 is superior articular process, and number 9 is it shows the articular surface over the inferior articular process. Number 7 is the disc space. Now the disc space is seen as here. There is the end plate of the vertebral body above, the end plate of the vertebral body below, the nucleus, and a good thick non-torn annulus, which is seen here, L4, L5, S1. The central canal, there is a mid-sagittal cut, so can see the maximum dimension of the canal very well. Then we also know that the annulus fibrosus is arranged in about 7 to 8 layers, and these lamellae are crisscrossed with different angles. The nucleus pulposus is contained inside this annulus fibrosus, and we can see that the nucleus is helping us to bear the weight, the loading. The nucleus receives the nutrition from subchondral arterial supply, and which diffuses through the vertebral end plate and supplies the nucleus. We acknowledge the images taken from Dr. Gillard from his website chirogeek.com. The nutrients are diffused into the disc through the end plates, and there could be a vascular supply only to the outer third. The main nutrient supply comes from the end plate and the sub-end plate area, where the vessels, that is the nutrient artery of the vertebral body, is also giving this supply. Now we need to know that these are the pedicles. There is the disc which is going out, there is the disc, there is the nerve which is going out, and this is the disc. This is the traversing nerve which travels down and goes out of the lower foramen. So our surgery, actually, we want to tackle this area, but for safety's sake we land here and then go for the axilla. And we need to also appreciate that in case of disc herniation and disc surgery, we will be landing on the floor of the segment. That is, we will be landing on the disc more in the lower part of the foramen. And in case of coronal section in a MRI, we try to understand this arrangement and try to rule out any conjoined root or a root anomaly. Now this is a cross section which will be correlated very well with the schematic diagram on the right side, but here we have to remember that this is the way the nerves are arranged, which may not be seen so clearly when we are looking at the MRI scan. This is a traversing nerve, this is the dural sac, this is the facet joint, this is the disc. The posterior aspect of the disc should be more concave, which looks little less concave here. And here we would know this is a supply by the sinovertebral nerve, which is a branch of the ventral root. And we also have the sympathetic fibers, the gray rami here, and we have the dorsal root ganglion situated in the foramen. Now we go next and we find that this is the sinovertebral nerve which is supplying the posterior part of the annulus. We also have gray rami coming, and we have the ventral root here. These are the pedicles where they have been removed as to expose the posterior aspect of the body. This middle part is the posterior longitudinal ligament, and this is the area which is very, very highly supplied by these nerves. So we need to remember that the gray rami are shown here, and all these sympathetics ultimately go towards the brain through the L2 ganglia or the L2 dorsal root ganglion. So if a patient is having pain in the back in this area and we want to stop that pain, we can also stop it by blocking the L2 dorsal ganglion. Now this is a basivertebral nerve. This also has an associated artery here, nutrient artery, which gives supply to the disc and the subchondral area. Now we have to remember here one more important point is that the disc is avascular, so it is never ever affected by tubercular infection, which is a hematogenous infection, but it always starts in the subchondral area of the vertebral body. Now here it is called as appearance like a Mickey Mouse, where this is the face and these are the long ears, where you see the nerves, the traversing nerve or the exiting nerve going out. This is already exited nerve, and these are the next traversing nerves. This is the dural sac. Now these are the vertebral bodies. The D is the disc. This is the mid-sagittal section, which shows the maximum width for the canal, and if this is narrowed, then we say there is a central stenosis. This is a parasagittal, which is normally at the level of the medial pedicle line, and what we do is we look at the canal size and we also look for the traversing roots at this parasagittal or the medial pedicle line picture. Then this is the parasagittal cut, and we will see this is the lateral part or a posterolateral part of the disc in the lateral recess, and it may be pushing the nerve, or this is the nerve, this is the disc going down towards the lower zone. Now here would be the pedicle, and this is a nerve just inside the pedicle where the nerve would be compressed by this herniating disc. Now this is a foraminal cut. You can see the foramen, which is like a keyhole. The upper part is pretty big, the lower part is small. The lower part is also important between the bone behind and the bone in front and the disc in front, and the upper part is mainly between the bone and the bone. So we have to look also for the hyperintense fat, and this fat is reduced in cases of chronic stenosis. Then this is a cut where we see very clearly the facet joint. This is at the disc level cut. There is the loss of concavity. There is the thecal sac. There is the neural foramen from here right up to here, and this could be called as a foraminal area. For herniations, there is foraminal, there is extraforaminal, there is paracentral, there is central. Now we revise again. There is the annulus, there is the nucleus in the center, the exiting nerve, and we see superior articular process, inferior articular process, the facet joint. There is the lateral recess if we are talking about the lower zone, and there is the foramen. Now lateral recess, when we talk about it, always has the pedicle as its lateral wall. So the lateral recess is below this. There is just an entry spot for the lateral recess. Now this again is the foramen, and you can see this will be the subarticular area, foraminal area, extraforaminal area. You can see the traversing nerves very well. Then we see here there is a very distinct tear in the annulus here. This is the annulus, this is the annulus, this is the nucleus coming in. There is bulging out, there is a loss of posterior concavity, and there is a compression of the dural sac. This is a middle zone cut where you see both the facets very well. Then here we see the ligamentum flavum. We see there is a loss of concavity of the disc, and then we also see the dural sac. We see this would be the dorsal ganglion. This is a little lower section, lower than the middle zone towards the lower end plate. Now this is again a middle zone section where you see the annular tears, and there is some portion in the middle which is below the ligamentum flavum, and we see the dural sac where all the roots are sedimented. A loss of sedimentation, as we know, is called as an important sign indicative of lumbar canal stenosis. The sedimented roots, the concavity, there's something happening here, extraforaminal area. So these were the MRI readings, and how to read an MRI was clarified In the sagittal sections, we look at the mid-sagittal, we look at the medial pedicle line, we look at the foraminal, and in the cross section we should look one at the upper part of the foramen just below the pedicle, one in the middle and one in the lower, which we'll be talking little later. Now, what does the surgeon want to know from the MRI? This is a talk mainly to tell you that there are so many things which we need to know, and we'll be going through the details one by one. Now, we need to look very carefully at this paper, which is talking about morphometrics of the entire human spinal cord and spinal canal measured from in vivo high resolution anatomical magnetic resonance imaging. Now, what does it mean is knowledge on morphological spinal cord characteristics are acquired through previous post-mortem or in vivo studies. In the past, it was mainly cadaver studies. Here, it is an MRI study. Measurements were made along the whole spinal cord in vivo on healthy volunteers and used to identify morphological characteristics that could be interpreted as the variants of human spinal cord. This helps us in enhancing the diagnosis and decision making towards conservative or active injury management. This was mainly related to the spinal cord morphology, and it was found to be distinctly different, statistically different between cervical, thoracic and lumbar spinal levels, but also in the postmortem or the cadaver specimens and in vivo specimens. And this study describes the values of the cadaver studies and the in vivo studies, highlighting the importance of the differences. And for us to understand the real in vivo dimensions, we need to go to this study. Now, this is another study where we need to know that we have to correlate pain with objective quantification of the image where the pain may be chronic in the lower part of the back. And we are trying to identify the relationship between the objectively measured and subjectively scored parameters. These were reported. This was a new application of MR imaging in identifying pain generators. Now, this was in 2014. This was for chronic low back pain, and quantified measurable parameters are better correlated than only the subjectively scored parameters. So what the paper says is that only narration by the patient, which will be talking about various aspects of the symptoms, are not only important, but the MRI parameters also have significance. We are trying to correlate the MRI with the degenerative cascade. As we know, the lumbar discs pass through three phases as they degenerate, starting with dysfunction, then the instability, and then the stabilization phase. The Kirkcaldy-Willis results are based on radiographs that emphasize the bony structures primarily. MRI focuses on disc composition in addition to calculated disc area. So here, important point is we are doing an MRI scan and trying to correlate it with three-phase spectrum of disc degeneration. Now, what it is talking about is in the second phase, that is the unstable phase, it shows early disc changes on radiographs and the patients experience localized low back pain and pain during movement with high percentage MRI index and are highly correlated with the pain. Stabilization phase, radiographs show degenerated disc with loss of disc height and osteophyte formation, and patient has decreased severity of low back pain with low percent MRI index and are negatively correlated with the reported pain. So what probably happens is in the stabilization phase, there is a healing of the annular tears and those changes which give rise to inflammation. Therefore, disc with high percent MRI index can be considered as disc going through unstable phase and are the potential cause of low back pain. So these are well aligned concepts with our traditional concepts that in the unstable phase the pain would be there, in the stabilization phase the pain would slowly settle down. The main thing is we now have this MRI study. The next study is a 2-year cross-sectional study of 114 patients with clinically suspected radiculopathy, either cervical or lumbosacral. And there is a total agreement between clinical with MRI and findings 72 and 52% respectively. That is, what has happened is EDX is electrodiagnostic findings. So here we find MRI correlates to 72 and electrophysiology to about 52%. The EDX and MRI was 59% in total and 49% with respect to clinical finding. So the point is electrophysiology, magnetic resonance imaging and electrophysiology, if we try to correlate with radiculopathy, they are not correlatable very well. They are complementary in general. It is reasonable to add electrophysiology when there is a discrepancy between MRI and clinical finding, or MRI neurologic findings are not visible. Then electrophysiology would be helpful and will clarify the problem for us. Now this is a paper talking about morphometric analysis of the working zone of the posterolateral endoscopic lumbar discectomy based on MRI. So it is talking about our line drawings, our targeting the foramen, landing in the foramen for surgery, and what are the distances, etc. And the paper tells us the measurements on the coronal plane, the height, the base, and the hypotenuse of the triangle. And of course, it is talking only about the height and base, and it is giving an angle about the exiting nerve. The height is in the upper lumbar area, it is from 9 mm to the lower lumbar, it is about 21. And the base is about 10 mm to about 15 mm. And we have studied the Camden's triangle in the standard cadaveric study. It was 12 and 18. So this is further in vivo measurement, and this is of more help rather than only cadaver studies. Now what we have done is, based on our understanding, we have done this study where we know that if we measure from the back to the front of the disc, it is about 9.3 centimeters or 93 millimeters. Then what we have done here is we have drawn lines on the left like this, which will be gently going through the peritoneal wall or the peritoneum, posterior aspect of the peritoneum, parietal peritoneum, and this is 13.3 and this is 13.8. But if we stay inside 13, then we are very safe. So in our patients, Indian patients with average height of 5 feet 6 inches in a male and around 5 feet in the female, we must stay between 9.5, which will be coming here, to about 13 and go at this angle. Then it is very safe for our access to the disc, especially in case of disc herniations, central, paracentral, foraminal, extraforaminal. Now, what we also have to understand is that there is a cascade effect in medical care, and this is a chain of events initiated by an unnecessary test, which commonly is a MRI. It results in ill-advised tests and treatments that may cause avoidable adverse events and morbidity, and this has been documented in many medical specialties. For example, electronic fetal monitoring, cardiac stress test, radiological lumbar imaging is also problematic, as it shows a lot of changes because of degeneration, but it may not have any significance because it doesn't really correlate well. MRI has become more frequent and it has no radiation exposure, but it is problematic because it is highly sensitive but not specific in identifying the cause of back pain. The impact of non-adherent MRI includes a wide variety of expensive, potentially unnecessary services and occurs relatively soon post-MRI. What it means is, the moment you have done an MRI, there will be a follow-up intervention which may not be necessary, or some conclusion from the MRI which may not be relevant. The impact is significant in the terms of cost of potentially unnecessary and unhelpful medical services, additional burden of a lost sense of well-being, and having a mistaken conceptual causal model and solution of one's low back pain is very difficult to estimate. It may be many cases where it is an unnecessary image which unnecessarily is highlighted. This study results provide evidence to promote conversations between the surgeons, clinicians and patients to help the patient choose care that is supported by evidence, free from harm, and which is truly necessary. So what we have to emphasize, this of course comes in counseling of the patient and answering their questions about use and utility of MRI. Now here we are looking at freehand real-time MRI guided injections where they have shown they are doing an epidural injection posterior midline, they are doing a transforaminal injection, and they are doing a transforaminal injection, periradicular injection. Now there is no radiation, but the costs are very heavy. So routinely we do not do a MRI guided injection, even though it is possible. Now there is another important aspect of imaging, which is the CT. And here we are going to talk about disc morphology at a posterior annulus after the discogram and CT scan has been done. What happens is, we have to remember that when we normally do a discogram, it is done under fluoroscopy, where we inject the disc and see the flow of the dye. We also listen to the patient about elicitation of the pain, and we find that the patient gets pain, the patient may have a leaking of the dye, etc., etc. But we are unable to see the cross-section of the disc, especially in a disc where it is a contained disc or posterior annulus may be intact or healed. So a post-discography CT is important in those patients where we may be able to see the internal architecture of the disc which had changed. So what we do is we are able to appreciate a complex and combination of annular defects with superimposed degenerative annular features. The contrast leakage associated with the relief with anesthetic. Now, in some patients where we do a discogram, we use the anesthetic, local anesthetic, to inject the disc. And in some patients we have found that the provoked pain can be relieved if the posterior annulus is not intact. The anesthetic will leak out and will relieve the pain. Now, the annular tears and the radial tears which project into a peripheral circumferential tear and also annular fragments can be seen in these studies of post-discogram CTs. Now here is a 30-year-old man, 4-year history of increasing severe low back pain with some left leg numbness. There is no injury. The MR degenerative changes with asymmetric disc bulges at 4-5. Now discography 4-5, 3 ml could be injected. It provokes severe concordant back pain. Lignocaine resulted in near complete elimination of the provoked pain. The axial post-disco CT, it shows a wide annular gap where you can see the curved arrows here. So there is a big annular gap and the free annular fragments present in the annular gap. So this shows the free annular fragments, and the discographic contrast leak was positive. There was a leak of the dye and this patient was relieved when we injected lignocaine. Now there is another study where we find this is a 33-year-old man, long-standing history of severe low back pain, worse for last 3 years. MR shows a disc degenerative change, in particular at 5-1. Now we do a discogram and we are able to inject 2.5 ml inside the disc. It provoked a severe concordant low back pain, 10/10. Intradiscal lignocaine resulted in no improvement of the provoked pain, and there was no leakage of the dye. Please remember this. And this axial post-discogram CT shows the circumferential lamellar annular tears, multiple free annular fragments, and peripheral annular tear where you have a curved arrow here. But there is no leakage here, and there was no relief of the pain by injection of lignocaine. Here is a 38-year-old man. There was an injury long time back. The patient had an injury about 16 years back, progressively increasing low back pain with some radiation on the left. The MR showed a degenerative disc change. Discography provoked severe concordant pain, 9 out of 10. Lignocaine resulted no improvement. Post-disco CT shows no leakage. So what we are trying to convey to you is that if there is no leakage, there is no relief of pain on injection of lignocaine. Now, post-disco CT development of annular gap is shown in this illustration from the paper. Now, commonly what has happened is, since we either do an open surgery or do a endoscopic surgery concentrating on those patients where we have a clear-cut disc herniation, these changes which are very important and which actually explain the causation of back pain many times are ignored. We need to be more aware of these changes. Now, how do annular gaps develop? Complex radial annular tears extending into peripheral circumferential tears lead to detachment of fragments of the annulus that become free within the central region. So we can see here A, B and C, they give rise to this G. So central annular fragments. Alternatively, peripheral circumferential tear, that is D and E, may become sufficiently detached from the outer annulus, giving rise to a sort of bucket handle tear, where you will find, we will see this like this, that is D and E will, there is a circumferential tear become like this F. Now this is very important, where we know that the internal architecture of the disc is shattered, and this may be one of the common causes of pain in the lower part of the back. Now this is the 3D reconstruction of the MRI, and we can see in this patient, where the patient is a 51-year-old man with left buttock and calf pain, where we have an extraforaminal change, and this is the radiculogram where you see the nerve root is lifted up on the right side in this, and then we also see there is a change here which has been marked extraforaminally, which correlates with the MRI and the 3D reconstructed image. There is another one with the left leg pain, where we see that there are changes around the periphery of the disc where there may be a leaking, and you find that the nerve is involved, the nerve is inflamed, whereas the posterior annulus, etc., seems to be normal. So what we have to do here is, on one side we have to remember that if we totally neglect discogram, which is what is happening nowadays, we are entirely losing the whole spectrum of inflammatory sciatica and back pain, which may be lost clinically by neglecting a simple investigation of discography. We have failed to correlate pain with these changes and only concentrated on heavy metal in many patients who come to us with back pain. We don't do a discogram, we only do a scan, which is not conclusive. We don't do a scan to demonstrate the leakage. We don't do a post-disco CT to demonstrate the annular damage. We so have not been able to do simple things like stage the sciatica and understand the subsets of sciatica, in addition to understanding the basic cause of back pain. It is better if we arise to the patient concerns and start doing the discogram in addition to post-disco CT or MRI, at least till the time we are much more mature about these changes. Now, there is a three-dimensional MRI and a nerve root and a radicular vein in normal and lumbar herniation pattern. Now, this is a 3D MRI STIR long T is superior to STIR TSE for not only detecting the root ganglion and the vein, but also displaying their pathoinjuries in disc herniations. So we can see the vein also. Now this is a paper talking about diagnostic accuracy of MRI, work perception, psychological factors in identifying symptomatic herniation. Now in age, sex and risk factor matched group of asymptomatic patients, disc herniation had a prevalence of 76% than previously reported unmatched group. Individuals with minor disc herniations are at a higher risk that their MRI are not the cause. I mean, the disc herniations seen in the MRI are not causal explanations of the pain, as there is a high rate of asymptomatic subjects. 63% had comparable morphological findings. Now, this emphasizes the point that MRI alone is not going to help us in understanding the disc herniation and the symptom generation. Now let's talk about MRI in stenosis. Now this is a middle zone picture and this has been termed as a stenotic canal. Please remember that there are 5 common or 6 common levels at which the cuts are taken. The first cut is at the mid-lower zone. Then the second is at the lower border of the pedicle, which is the start of the upper zone. The third is at the lower border of the body or just in the disc plane. The fourth one is in the upper end plate of the lower vertebra, that is the start of the lower zone. The fifth is in the middle portion, that is the first one, is the lateral races or the lower zone, and the sixth is through the pedicle, lower pedicle. Now, out of these 3, we must understand the 3 which have been marked with the blue outline. The upper one, the first one, is the upper zone at the lower border of the pedicle, and you will find that the foramina are open. There is no superior articular process. It is only inferior or the lamina. In the second, which is the disc or little in the upper part of the disc, where the foramina are open, they may show the dorsal root ganglia and you see the facet joint. Here it is lamina and the inferior articular process. And in the third, there is the lower zone where you see the facet joint, but important is pedicle. The lower pedicle is seen. Here no pedicle, no pedicle, pedicle. Here no superior articular process, both superior, inferior. There is only inferior. Here the real facet joint with everything. So this is upper zone picture, middle zone picture, lower zone picture. You may have to revise your understanding by listening to this again. In case of lumbar canal stenosis, this is an important study about the width of the canal and what all things happen as the age progresses. The width becomes almost twice than at the birth. The AP diameter becomes almost 1.7 times and the height becomes about 5 times more. The height is 0.8 centimeters for the vertebral body here, and here it becomes 4 centimeters. So we need to understand this very well as the change as the age progresses. Now the MRI also tells us about the texture of the disc. Here in the coronal image you see a paracentral herniation which is matched by a cross section, and you will find that the disc otherwise looks blackish. There's some gray area, but this is extremely black or very, very black. So this is a hardened fragment, and why this is important is because we need to be very, very ready for the instrument breaking down if you are a beginner. Then we also do a MRI in cases of fold back surgery, and we also add a radiculography. We remember that we are dealing with this Cambin's triangle, and this is where we have been able to clear the foramen. This seems to be only partial clearance, and only a partial clearance of the herniation where we have not been effective in tackling with this and tackling with this tissue. Now the MRI is mainly done also for post-op changes and in case of instabilities, and there is a software developed by NosiMed. It is called a NosiScan, which helps us in detecting painful lumbar disc when we do a MR spectroscopy. So what we can say is that, in summary, disc biochemistry and structure failure is seen in the MRI. The question of pain generation cannot be answered fully by MRI. The MR may be used for guided interventions like injections, etc., etc. The MRI has limitations with respect to vascular reactions, and unless we do a gadolinium scan, we will not be able to know what is happening to the vessels. The oblique course of the nerve root is not seen in the MRI unless we do an oblique MRI or a 3D reconstruction, and a lateral annular tear also is not seen in the MRI. In vivo visualization, putting a scope and looking at the pathology and correlating it well with the pain in a patient who is awake and aware is the real solution, which supports our contention that our system of transforaminal endoscopy, which is stitchless and under local anesthesia, is the best way to tackle all these problems. Thank you.